Hello, my name is Cherie Minet. My partner, Hunter Louviere, and I are senior student registered nurse anesthetists. We will graduate this December with our doctorate of nursing practice in nurse anesthesia. A part of the requirement for graduation is to complete a DNP scholarly project. So here is ours. Together, we developed a systematic review analyzing current literature for information regarding ketamine's efficacy in reducing postoperative pain scores in surgical patients, as well as its ability to reduce opioid consumption. Pain is a complex phenomenon that affects all individuals. Pain signaling, or nociception, can follow pathways similar to that of neural sensory pathways, but can also be modulated or enhanced due to the release of chemicals in response to tissue damage, such as an injury or surgical interventions. In addition, the individual human factor also affects how pain is experienced, as each patient's personal and medical history, as well as perceptions of pain, can be unique. All considerations must be taken into account when developing an anesthetic plan that includes appropriate pain management techniques. Ineffectively managed pain can have a profound effect on a patient's recovery, function, and quality of life following surgery. It is our job as anesthesia providers to seek measures to improve the postoperative pain perceived by our patients. In doing this, we can also decrease the amount of opioids being consumed. In this presentation, we will discuss one approach of pain management through the utilization of alternative pain pathways, specifically the preoperative administration of low-dose intravenous ketamine. One significant component to improving pain management outcomes is decreasing the amount of opioids we are using, contrary to the traditional techniques that have long been centered around opioid-based analgesia. Opioid use for chronic pain management was endorsed by the American Academy of Pain Medicine in 1997, causing the sale of opioid pharmaceuticals to skyrocket. By 2008, the economic cost of pain management and lost productivity in the United States alone contributed to nearly $600 billion in health care costs and lost revenue. According to the Centers for Disease Control and Prevention, in 2017, approximately 191 million opioid prescriptions had been filled or refilled by more than 56.9 million people, resulting in a total opioid prescribing rate of 58.5 per 100 persons. Additionally, deaths related to opioid use in the United States have increased nearly 6 times that of the rate in 1999. There is a definite association between surgery and the current opioid epidemic. According to Ha et al., surgery represents a critical event where the majority of patients are exposed to opioids, regardless of whether or not they have had prior opioid-related adverse events, including overdose. The use of adjunct intravenous medications, such as ketamine, is one of many trends being explored to effectively manage pain without or at least minimizing the use of opioids. One widely accepted theory regarding pain modulation is the gate control theory of pain. Introduced by Ronald Melzack and Patrick Wall in 1965, this theory suggested that pain signals transmitted through the peripheral nerves and the spinal cord are modulated both intrinsically and in the brain. They theorized that the signaling pathways in the substantia gelatinosa and dorsal column of the spinal cord served as the gate through which pain can be modulated from C and A delta sensory afferent fibers. Alteration of this gate can be achieved at various sites within the brain through mechanisms that can affect the descending pathways and ultimately the pain perceived. As research has evolved and more information related to various neurotransmitters, mechanisms of pain, and pain signaling has developed, the theory still holds true and guides methods of analgesia utilized in practice today. In addition to the gate control theory, Melzack and Wall introduced the concept that repetitive discharges of spinal neurons leads to the phenomenon known as wind-up pain. This repeated stimulation potentiates the release of peptides, which prolong both synaptic potentials and the depolarization of N-methyl D-aspartate, or NMDA, receptors, leading to an increased central sensitization and increasing the spinal processing of nociceptive input. These concepts demonstrate that pain modulation can be achieved through alterations in pain signal transmission. With that said, the use of ketamine, an NMDA receptor antagonist, can potentially alter these mechanisms of pain signal transmission and central sensitization prior to surgical stimulation to potentially reduce pain and opioid consumption in order to improve the overall outcomes and surgical experience. It should be our goal as anesthesia providers to seek alternative measures of pain management in an effort to provide better outcomes for our patients, as well as to do our part in making improvements in fighting the opioid epidemic. With this systematic review, 9 studies were analyzed to determine whether or not the preoperative administration of low-dose intravenous ketamine demonstrated decreases in postoperative pain scores and reduced opioid consumption during the first 48 hours following surgery. Specific inclusion criteria for studies selected in the review consisted of patients undergoing surgery with general anesthesia, where at least one group of study participants was administered an IV dose of ketamine prior to surgical incision. This intervention was to be compared to alternative administrations varying by dose, timing, or method of administration, such as IV bolus versus infusion. The desired outcomes, in order to be considered effective compared to that of control groups, were reductions in pain experienced by the patient, demonstrated by decreased pain scores and decreases in the amount of opioids consumed by the patient during the first 48 hours postoperatively. Inclusion and exclusion criteria was established to maintain consistency among study participants, as well as to remove limitations that may have altered results. This was done to optimize both internal and external validity of the study results. The types of participants in the selected studies included ASA classifications 1 and 2. One study also included ASA 3 participants as well. All patients were followed for up to 48 hours postoperatively for evaluation of the intervention delivered. Exclusion criteria included allergies to ketamine, history of substance abuse, psychiatric illness, chronic pain syndrome, liver disease, hematologic disease, morbid obesity, communication disabilities, or inability to use a patient-controlled anesthesia or PCA device. Studies were selected for review if they evaluated the efficacy of IV ketamine administered before surgical incision on postoperative pain and opioid consumption. Studies that did not include IV administration of ketamine before surgical incision were excluded. Aside from the intervention of interest, all participants received a standardized plan of care and anesthetic technique throughout the preoperative, intraoperative, and postoperative periods. In the selected studies, the intervention of interest was compared to no intervention, alternate timing, alternate methods of administration, and/or the administration of a placebo. Alternate methods of administration included IV bolus versus continuous IV infusion, or a combination of the two. Not all studies included a placebo group. The outcomes measured in selected studies included ketamine's effectiveness in decreasing postoperative pain perceived by patients and its ability to decrease the total number of opioid medications required by patients during the immediate postoperative period. While pain perception is subjective to the individual and may be considered qualitative in nature, pain was documented using the linear or numerical pain scale in order to provide a quantitative means of measurement in order to display results. Measurements of opioid consumptions were quantitative and included cumulative totals of medication required, and in some studies included the time to first dose of opioids received by the patients.
Prior to the literature search, the research question was developed using the framework Population, Intervention, Comparison, and Outcomes, also known as PICO. The research question was then divided by population, intervention, and outcomes with additional related search terms included. There was no comparison group for the research question. Population was searched included surgical patients, operative patients, operation and surgical candidates. The intervention search included perioperative ketamine, ketamine before surgery, ketamine IV bolus, ketamine before induction, and ketamine pre-induction. Outcomes searched were pain scores and opioid requirement reductions, opioid consumption and post-surgical pain, postoperative pain, and opioid sparing. The search engines utilized were CINAHL, Ovid, PubMed, Medline Complete, ProQuest, and ScienceDirect. The expanders used were apply equivalent subjects and related words. The initial limitations included articles in the last 5 years, published in English, and human studies. The yearly limiter was expanded to 20 years to generate a larger number of research articles. The search yielded 95 articles, which were then entered into the Mendeley reference management software. Dukelet screening removed 63 articles, leaving 32 for abstract screening. 21 were excluded due to the administration route of medication irrelevant to the search criteria, the timing of administration, and the study's objective outside of post-operative pain control. The remaining 11 articles were critically appraised using the Joanna Briggs Institute Critical Appraisal Checklist. One article was excluded due to the lack of insight on methodology used in the study. The other was excluded for postoperative pain reduction not being thoroughly analyzed. A total of 9 studies were included in the review, 8 randomized controlled trials and 1 case control study. A total of 728 patients were included across all studies. Countries of origin include United States, China, Turkey, France, Jamaica, Pakistan, Spain, and the United Kingdom. Anesthesia administered for all studies was under general. The studies included surgical procedures that were laparoscopic and open gynecological surgeries, transurethral prostate resections, colon surgeries including colectomies, appendectomies, and also included total mastectomies. There were 2 emerging themes from the selected studies. First theme identified was effects of preoperative intravenous ketamine bolus on postoperative pain scores. The findings were mixed among studies. For less invasive, short duration procedures like transurethral prostate resections and laparoscopic gynecological surgeries, there were statistically significant reductions in pain scores. Open gynecologic surgeries and total mastectomies, there were no reductions. For colon surgeries, there were actually higher pain scores in the ketamine group, though not statistically different. For the pediatric population undergoing appendectomies, there was no reduction in pain scores. The second theme identified was effects of preoperative intravenous ketamine bolus on postoperative opioid consumption. Again, for less invasive, short duration procedures like laparoscopic gynecological and transurethral prostate resections, there was a statistically significant reduction in opioid consumption. Total mastectomies, no reduction regardless of preoperative or closure administration. For open gynecological procedures, there was no reduction in opioid consumption. And for pediatric appendectomy, no reduction in opioid consumption as well. No studies demonstrated a negative effect on an increase in postoperative opioid consumption compared to controls. In conclusion, ketamine administered as a one-time dose before induction is not consistently effective across studies. One study reported a better patient satisfaction in the ketamine group but did not produce reduction in either theme. Ketamine does have a role in the postoperative pain management, but not as a single dose pre-induction, and is not beneficial across all surgical procedures. There are a number of limitations and strengths identified. Collectively, there is a lack of research studies focusing on preemptive administration of ketamine alone. Most studies assess ketamine's use across the perioperative setting. Some studies lack the standardized intraoperative anesthetic management plan, leaving an uncontrolled variable of synergism with the co-administration of intraoperative opioids and its influence on postoperative pain control. In some studies, large surgical procedure variation, its degree of invasiveness, and the length of procedure could affect results. Several studies lacked a placebo control group as well. Strengths include that all studies use statistical analysis for increased validity, and this systematic review provides insight for future research such as optimal timing in smaller, less invasive procedures and the timing of NMDA receptor antagonism leading to possible escalation of pain perception. The implications for practice are as follows. Based on the systematic review, recommendations in the practice change are not indicated and generally support a lack of benefit. Subanesthetic pre-induction ketamine is not a standardized practice currently, and based on a systematic review, it is not recommended to include pre-induction ketamine into standardized practice. Implications for future research include a focus on less invasive, shorter duration procedures, especially involving genitourinary surgery. Also look at the different timings of administration and potentially upping the dose to 0.6 to 0.9 milligrams per kg, and also potentially adding a low dose infusion of 1 to 3 mics per kg per minute and assess its effects on pain control and side effects. The remaining slides includes all references used. Thank you for your time. Have a great day.